Good evening, friends, and good morning to Dr. Fadi.
Morning.
On behalf of Karnataka chapter of ISAR, I welcome you all to this webinar on protocols to improve ovarian response in poor responder. I am Dr. Shobhana Patel. I am the chairperson of Karnataka chapter of ISAR. I have with me Dr. Madhuri Patil, who is the founder president of KISAR, and Dr. Srinivas, who is the past chairperson of KISAR, and Dr. Manjunath, and who is the vice chairperson of KISAR. The management of patients with impaired ovarian reserve or poor ovarian response to exogenous gonadotrophin stimulation has challenged reproductive specialists for a long time. It forms a big chunk of our ERT practice. Apart from our limited understanding of its pathophysiology, there is a wide heterogeneity in the definition of a poor responder. It's interesting to note that a systematic review of 47 RCT revealed there are 41 different definitions of POR, and no more than 3 trials use the same definitions. And even trials from the same research group used different definitions. And earlier we had this Bologna criteria to standardize the terminology, and then we have now more clinically relevant criteria, Poseidon criteria. However, still there is no solid recommendations for its management, or we don't have any magic bullet protocol. To talk about this complex and controversial issue, we have none other than Dr. Fadi Sharara. It gives me great pleasure to introduce Fadi Sharara. And I went through his CV. It runs about 48 pages, and he was so modest. When I asked him to give him his CV, he gave me only 3 lines. So I said, nothing doing, you're going to give me the full CV. And then he sent his CV. Very, very impressive. I'm really happy to share his achievements with you all. He's a medical director and founder of Virginia Center for Reproductive Medicine, clinical professor at Department of OBGYN at George Washington University School of Medicine at Washington, D.C. He has a dual fellowship achievement, and he has got a fellowship in reproductive endocrinology and infertility, and also in obstetrics and gynecology. Probably that makes him something unique. His IVF center has been ranked 3rd on the SAR charts for his case success in the US. And he has demonstrated expertise in wide areas of ERT, be it from vitamin D, embryo transfer, and hydrosulfings, and poor responders, and surrogacy. Lot of area where he has published papers and he has worked on this area. And he has developed a very popular app which is called as an infertility diet app. I don't know how he moved from this area to the, probably we want him to tell about it. And so because of his success, we want him to share his secret recipe with us today. And he has published more than 80 scientific papers and book chapters. He has actively participated in various clinical trials to improve ERT success and to prevent OHSS, and also protocols to help improve ovarian response in poor responder. He has got plenty of honors and awards, and I was wondering whether he is a man with a Midas touch. Wherever he has gone and touched it, and he has won an award. He has got the Dean's honor. He's in the Dean's honor list in Faculty of Medicine. He was an outstanding resident in endoscopic surgery. He got an Young Investigator Award from Serona. He was a semi-finalist in Wall of Fame, Outstanding Faculty Teaching. He has got an Established Clinician Award by ISRE, and he is considered obviously as one of the America's top obstetrician and gynecologist. Ladies and gentlemen, I present to you Fadi Sharara. He is one of the most fantastic I would say clinician, a researcher, and teaching faculty, all in one. So I present to you Dr. Fadi, and Fadi, the floor is yours now.
Thank you, Dr. Shobhana. That's you made me blush. That's why I sent you a 3-line CV, because this makes me uncomfortable. But thank you for the kind introduction. I really been involved with many areas of the field. And first, I'd like to thank, obviously, Dr. Madhuri for the kind introduction. I would have loved to be personally with you all in India. India is one of my favorite places in the world. I've been at least 5-6 times to India over the past 5-6 years, and including the last ISAR meeting, which was my last meeting. So I'm going to share my screen here. Let's see. Okay. All right. And so I'm going to speak about the management of the poor responder and evidence-based approach. And as you can see from the slide, I have Dr. Jatin Shah's name in here. For those of you who were at ISAR and came in and attended the Ferring Symposium that was presented, Dr. Shah gave this phenomenal talk on poor responders back in, on March, I think March 6 or March 7. And his was such a phenomenal updated review that I asked him if I can use many of his slides. And probably 85% of the slides I'm going to share today are from his presentation. So obviously, I have to give him credit first rather than me making the presentation. So this is a joint presentation between me and Dr. Jatin.
Paddy, can you put it on slideshow?
Let's see. I think I did. Slideshow. Okay, I see. So here we go. Here we go.
Yeah.
Is that good?
Yeah.
All right. So as I was mentioning to Dr. Maduri and Dr. Shobhana, ISAR was the last conference I attended before COVID-19. It probably was the last conference that all of us have attended before COVID-19. And this is a picture that was taken on March 7th before I went to the airport and got to Washington. And then obviously the whole world completely changed at that point. So let's start with the talk. So this is a very famous slide from an old paper from 2011 right now by Sunkara that looked at number of oocytes retrieved and live birth rate. Now remember, this slide is really related to fresh embryo transfers. Okay, so we can talk about frozen afterwards and whether this holds in frozen cycles or not. But the ideal number to maximize live birth rate in a fresh transfer is about 15. Okay, now obviously when we're talking about poor responders, we never get to this number. They become actually normal or high responders at this point. So the poor responders are all these women that we only get a very low number of eggs from. There's various definitions, as Dr. Shobhana mentioned, but really the worst outcomes are those who give us 1 to 3 eggs when we do an IVF cycle. And as Dr. Shobhana mentioned, this is a review paper from 2011 that she mentioned. There's 47 randomized controlled trials on poor responders, including 41 definitions, including age, previous cycle response, enteral follicle count, FSH, number of follicles on the last day of stimulations, number of eggs retrieved, the estradiol on the day of HCG, how many good quality embryos, FSH dose. So, it's like the definition of pornography. We all know what it is, but it's very hard to really define. So we all of us who are clinicians know a poor responder when we see a poor responder, but because of so many definitions, this makes at least when you write about it, so much harder. And again, this is just from that paper, the different interventions for poor responders, some antagonists to growth hormone, to adding HMG, to long protocols, microdose flare, increasing FSH doses. So adding metformin, arginine, CoQ10, DHEA, testosterone. So all of these things have been looked at as interventions for poor responders. So we have to look among all this fog and try to understand, does really anything help? So what's the physiology of poor ovarian response? Obviously, we have few things. The biggest one is the presence of a reduced number of FSH-sensitive follicles. Basically, there's very few eggs left, and that's the real definition of diminished ovarian reserve. In many cases, it's suboptimal exposure to gonadotropin, meaning you've given this patient less gonadotropins than she should have given. Obviously, bigger women would necessitate a higher dose. And in few cases, you have FSH receptor polymorphism that makes the follicle itself less sensitive to gonadotropins. Now, what are the proposed criteria for this? This is basically the Estuary consensus, the first one from 2011, which was quite confusing. They used age as one of the criteria, but we all have had women 41, 42 that can give us 20 and 25 eggs. And these are definitely not real poor responders. So they looked also at low number of oocytes. They looked at the abnormal ovarian reserve, especially AFC and AMH. And therefore, the Poseidon definition came in to try to create some more uniformity for this Bologna criteria. And specifically, looking suboptimal response became a whole category and versus high poor response, and then combining qualitative and quantitative parameters in this definition. So if you see from the left side, you have group 1 and group 2 and group 3 and group 4. I'm going to go into those in slide details. And therefore trying to make individualized control ovarian stimulation. And for many years, when I read individualized, I would sort of laugh, because when we see a patient, and all the women that are in the audience, you cannot, every woman is different, and you cannot have a standard treatment regimen for everybody at the same time. So for at least for the past 25 years, I've been practicing individualized ovarian stimulation. You look at that couple, you look at the woman, age, BMI, AFC, AMH, previous response, and then you devise a regimen for that specific woman. So for me, the concept that they've been introducing in Europe called individualized ovarian stimulation is a bit interesting. So this is the Poseidon criteria, which were published in FNS in 2016. And they broke them down into young and older, okay? Not old, older. You can't tell a woman that she's old. So for the women that are less than 35, when you look at their ovarian reserve parameters, you have an AMH above 1.2, an AFC above 5, and then they broke them down into group 1A and group 1B, whereby the AFC is less than 4, or number of oocytes retrieved in a prior cycle, less than 4 or 4 to 9. But many times we don't have a prior cycle to go by. Group 2 is older than 35 or older. Same thing, AFC above 5, AMH above 1.2, again, subgroup 2A and 2B, okay? So these are practically normal responders. One is young and one is older. The poor responders can obviously occur at any age. Less than 35, AFC less than 5, AMH less than 1.2. Believe me, I would love to have a 1.2. What we're dealing with mostly are women with AMHs above 0.7. So the 0.3 and 0.2 and 0.4. And then basically you have the older women, 35 or older, with the same definition, AFC less than 5 and AMH less than 1.2. So again, what we can glimpse from this is basically you look at age, you look at ovarian biomarkers, especially AMH and AFC, and number of oocytes retrieved if in a prior ovarian hyperstimulation cycle. Now, the AMH and AFC, at least between the US and Europe, there's still this big discrepancy. So AMH is very, very popular in Europe. In the US, AFC is more popular. But we still look at both. And we've all had cases where the AFC and the AMH do not really correlate. You have somebody with an AFC of 4 having an AMH of 1.3. That just doesn't correlate most of the times. And sort of vice versa. And poor responders, at least in my clinic and in many clinics, they represent easily 50% of patients. So what are treatment strategies for expected diminished ovarian reserve or premature or poor ovarian response? So for pituitary suppression, we're going to talk about all these things. You can use an antagonist cycle or an agonist cycle. Stimulation challenges. What type of gonadotropins? Do you have FSH only? Do you add HMG? Do you add recombinant LH to your treatment? What's the maximum gonadotropin dose? That's a very, very important concept. And then do you use natural cycle IVF or mild stimulation? Where does the literature stand on those? And then I'll introduce later the dual stimulation, or what's called duostim. And then the adjuvant therapies, especially androgens and growth hormone. So the management for groups 1 and 2 obviously differ Again, the group 1, as I told you, the younger than 35 versus group 2, the older than 35. The reason for low response, these are sort of the normal responders. If you don't get many eggs, it's because you undertreated them. You did not include the BMI along with this. Now, luckily, this is not a problem in India. It's a huge problem in the US. And what dose are you starting? You know, in the US, we don't start with 150. Even in PCOS patients, most of us start at 225 and then drop. So we're much more aggressive in ovarian stimulation. And, you know, is there genetic polymorphism of the FSH receptor and specifically asynchronous development? These happen more commonly if you don't put people on the pill beforehand, or you bring somebody and you start them on day 2 or day 3. There's already 1 or 2 follicles that are 10 to 11 millimeters and the rest are behind. Obviously, these 2 follicles are going to grow much faster and you get this asynchronous development and you're not going to get many eggs. So treatments, obviously, you can change at that point. You can use antagonist or estradiol pre-treatment. You can use agonist, add HMG. You can increase the RAC FSH dose. You can add recombinant LH or HMG or use HMG instead of FSH. Now, what about luteal phase estrogen with antagonist? Okay, this is one of the protocols. You start estradiol valerate 2 milligram BID on day 25 before your cycle. The rationale is to decrease the risk of cycle cancellation, increase chance of pregnancy, but most importantly, improve synchronization of the follicular pool. And this is one study published in 2011 comparing this, and you see that when you do luteal estradiol versus no estradiol, the cancellation rate is substantially reduced. You get about 1.3 more eggs, and number of embryos is about the same. But estrogen priming can work in these patients. I use this protocol. So I actually start on day 21 of the prior cycle. If you don't want to use GnRH agonist, this is one way of trying to synchronize the follicular pool. So you give estradiol 2 milligrams BID starting on day 21. You give it, basically you stop, they get their period, and then you start ovarian stimulation at that point using an antagonist protocol. And this is one paper published from 2011. There have been few papers since, but using GnRH antagonists for 3 days before you actually start the cycle. And the whole point is exactly the same thing, to try to synchronize that follicular pool. So you try to stop the growth of these 10 or 11 millimeter follicles until you really get stimulation going. This is the study from the Belgian group looking at the amount of FSH that was, there's no difference between the control and the pre-treatment. Days of stimulation was the same. Number of oocytes was much higher, and the ongoing pregnancy rate was much higher. Remember, this is all fresh transfers. So what about agonist versus antagonist? Okay, I still use agonist in about maybe 30% of my patients. Many of the clinics around the world have stopped using GnRH agonists at all. I think that's, I think GnRH agonists still have a role to play. So this is a paper that was published by IVF Worldwide from 2010, looking, it's a survey. So 196 centers participated from 45 countries, looking at what type of protocol do you use in poor responders. At the time, that's 2010, so more than 50% use antagonist cycles. If you do this survey now, I will tell you probably more than 95% of clinics around the world use antagonists rather than GnRH agonists in a different format. So in this survey, the real long protocol was only used in 9%. So what's the rationale of using an agonist? Okay, we thought actually then when you use an agonist, you may oversuppress these patients, and that's really not the case. You get better synchronization of follicles. Obviously, more follicles that grow are better in these poor responders because they're not going to make many, and you get higher number of oocytes and higher number of embryos with vitrification. And this is a recent study published in 2019, but we're looking at a large database from China, 577 cycles in antagonist, 654 cycles in agonist. The days of stimulation is more with agonist. So on average, you get a day extra. Dose of gonadotropins obviously is going to be more. Estradiol is going to be higher with antagonist. Endometrial thickness is, here it's about 1 millimeter more, and this is a good thing. Number of oocytes retrieved was higher. Mean number of 2PNs was higher. Number of embryos available was higher. And number of embryo transferred was 1.74 and 1.92. Even though this is statistically significant, I'm not so sure it's really clinically significant. The ongoing pregnancy rate is higher, and the live birth rate was higher. So I totally believe that agonist protocols still have a place in these poor responders. And when you do the frozen embryo transfers from these cycles, actually you find out that the pregnancy rate from agonist protocols are a bit higher than in antagonist-based protocols. This is another study from 2018 looking at the Poseidon criteria, group 3, again showing that with the agonist, this is the fresh day 3 transfers, and you get basically 27.6% versus 13%. So again, a higher pregnancy rate and live birth rate. All right, so what about increasing the gonadotropin dose? So let's start with that. So this is from that survey in 2010 I mentioned previously. What's the starting dose for gonadotropins? 85% of clinicians around the world use more than 300 IUs. So if you look at this, some even went to more than 600 IUs per day. Thank God it's only in 0.3% of cycles, but 450 to 600, which I think is way overkill, is still used by about 24% of clinicians around the world. And if there's something that I would want you to do from this, it's please do not go beyond 450. There's absolutely no advantage. There's a study from Canada that showed 300 may be the maximum dose. But again, in the US, because we have bigger women, I personally have never gone above 450. These follicles, if they're not going to grow with 450, don't think they're going to grow with 600 or more. So all you're doing by using more gonadotropins is making this cycle more expensive for that specific couple. So increasing, this is again a paper from 2017 in Poseidon groups 1 and 2. Remember, these 1 and 2 are the ones with unexpected poor response, and therefore increasing the dose in the second cycle by 50 to 75 can help improve the pregnancy rates. I will tell you, in poor responders, you do not have to really worry. And for those, I routinely start with 450 from day 1. And again, you see by increasing the dose in here, it's very clear that you get a linear increase in the number of oocytes that you would get. They didn't go beyond 300, but you can see clearly when you have somebody with you start them at 150 or 200, you're practically going to double the number of oocytes that they're going to get when you increase that dose. What does 1 extra oocyte mean to the patient? Again, this is a slide from RBM Online that Dr. Shah had, and I think it shows this concept beautifully. So the chance of a live birth increases exponentially with the number of oocytes we get. So if you get 1, the live birth rate is 3.8%. If you get 2, it's 8.5%. You get 3 eggs, now you're at 12.4%. 4 eggs, you're at 16.7%, and 5, you get 22%. So a humongous increase in the chance of a live birth by increasing with just 1 egg at a time. Now, what about the patients in 3 and 4? Those, they're going to be poor responders, okay? What do you do with these people? And the reasons, as I discussed, age-related, quantity, and quality. So these are usually, especially in the older 35. So if you get 2 eggs in somebody who's 29, obviously her chance of getting pregnant are going to be substantially higher from somebody who gets 2 eggs at 42. Okay, still age trumps everything. Okay, so as women age, you get what I call the double whammy, which is the decrease in both quantity and quality. And remember, AMH and AFC and all these markers of ovarian reserve are markers for quantity, not quality. Quality is really age. But with poor ovarian reserve, especially in group 4, which is the older women, you get the double whammy, the quantity and quality decline. Other cause of low reserve, obviously, if you had somebody who had an endometrioma that removed half the ovaries, previous chemotherapy, there are genetic cause of low reserve. So I'm talking about women who are Fragile X carriers, for example. Some women with BRCA2, for example, may not do as well. And, you know, obviously unexplained. But when you get somebody coming in with an AFC of 3 and an AMH of 0.4, that's really not unexplained at this point. So what do you do for these couples? As I discussed previously, agonist or antagonist, but you can also try different stimulation. So if you're a REC-FSH heavy practice and you tried them on REC-FSH and they didn't do that well, please consider adding HMG to the next cycle, okay? So one other thing that I'll discuss later is embryo banking. Would you do PGTA? And obviously the duostim is one of those. But the biggest question for us, and that's why you're all here, does anything really help? Okay, and I'm going to go over points like increasing gonadotropin dose. Does the addition of REC-LH of HCG help? What about supplements like CoQ10 or DHEA? What about transdermal testosterone? Does growth hormone help a little bit? I spoke a bit about GnRH and antagonists. I'm going to go a bit more with this. Embryo banking, freeze all, PGTA, and duostim. I'm going to review all of these. So the maximum gonadotropin dose, I mentioned briefly, but this is a paper, an old paper from 2010, showing that basically there's no advantage to really going above 300 for our patients. So the pregnancy rate, the live birth rate is 10.5% with 300. 450, it's 7.7%. At 600, it's 9.5. And so there's really no advantage. If you have a thin patient in your practice, I think going beyond 300 isn't of a difference. No matter how much you increase, the outcome is the same. That's really the message here. What about, so this is a paper from Europe. Obviously in Europe, they're extremely gentle in their stimulation. So it's not unusual for practice to start with 150. So I will tell you, if you have somebody that you know is going to be a poor responder, please do not start them at 150. You may get 2 or 3 eggs, but you're not going to get the maximum dose. So I will tell you at least double that dose and see how that patient is going to do. What about, so this, I get asked this question quite a bit, and Dr. Shah definitely looked at this. This is a paper from 2018. And what about converting to IUI? So you have somebody, you do a cycle and they have 2 or 3 follicles, and you say, nah, this is not good enough, especially in real poor responders. So in the subgroups 3 and 4, not in 1 and 2. In 1 and 2, if they're not done well, because you didn't give them enough medications, it's understandable. You can cancel that cycle, make it into an IUI. But in the real poor responders, if you have 2 follicles or more, going with IVF is definitely associated with a higher chance of pregnancy than doing IUI. Okay, if you have 1 follicle, there's no difference at that point. They both do extremely poorly, as I showed you, with a live birth of about 3.2%. But when you have 2 follicles or more, and there's no guarantee that that patient is going to do any better in a different protocol at that point. So I would go, I've gone with as few as 1. Obviously, if you have somebody with a tubal factor, but for two follicles, you know this patient is not going to do better, do IVF better than moving on with IUI. What about clomiphene versus letrozole? I'm just going to show this one slide. Clomid is better in poor responders than letrozole. There was also a paper that was published in the American literature about 2 or 3 years ago, looking at unexplained infertility. And in unexplained infertility, taking letrozole does worse than actually going with Clomid. I personally don't use Clomid. I use tamoxifen because Clomid is an anti-estrogen on the brain and on the uterus and on the cervical mucus. compared to tamoxifen, which is an estrogen agonist. So my patients do not get hot flashes, suicidal ideations. Their lining is obviously always better because in Clomid, about 10% of the times you get a thin lining, even though the chance of pregnancy is not reduced when the lining is thinner. But it's better to use tamoxifen rather than Clomid in these patients if you want to try like a combination of just tamoxifen alone. If you're using Clomid along with gonadotropins, the increasing in estrogen will counteract the effect of Clomid on the lining, and you will get a decent lining. So let's go back to this slide. So the second item is, what about REC-LH versus HCG addition? So who do you use that for? Elderly patients, I use that from day one. We don't have REC-LH in the US. It was pulled off the market in 2010 because nobody was using it and it wasn't helping. But we have, the only HMG we have in the US is Menopur, which has HCG in it, okay? So this is what we use. You know that you want to give them the best chance possible during that cycle. They may not have enough money or insurance coverage to come and do another cycle. So you really want to optimize their chances from the beginning. So you start from day one. There's ample data right now that you need to start these from day one and not wait until day 6 to 7 until you start this, okay? To reach steady state, you need about 6 days. So you really need to start from day one. So addition of REC-LH does not increase the number of oocytes retrieved, total dose of FSH, cancellation rates, or ongoing pregnancy rate. And these are 2012, 2013 meta-analysis. But there's other studies have showed that adding REC-LH versus REC-FSH alone can help in poor responders. So if you do not have Menopur and you want to use REC-LH, you can, or you can add HCG to the REC-FSH. So that's one thing. And remember that HCG is substantially more potent than LH. So it's 7 times more potent than LH with a significantly longer half-life. So the half-life of HCG is about 36 hours. That of LH is 6 to 8 times shorter, just like, you know, human LH. It just disappears much faster. And this is HCG and this is LH. And increasing HCG, this is a study from 2007 from the MERIT trials that were done in Europe, showing that the higher the HCG level on day 6 of stimulation, the higher the number of top quality embryos. And this is from that study, but unfortunately it's not showing here. But basically what it shows you is the live birth rate increases exponentially with increasing HCG level versus LH level is absolutely unchanged. Because in this study, Menopur has no LH at all. And obviously recombinant FSH does not have any LH. What's in Menopur is 10 IUs of HCG per vial, and that is enough to increase your HCG level by day 6. But it stays quite low. So the maximum I've ever seen was about 9. But most of the times it's about 3 to 6 IUs per liter. What about CoQ10? These are the supplements. So I personally recommend all my patients take this from day one, from the moment I have my initial consult with them. This is a trial from 2018 showing that giving CoQ10 increases the higher peak E2, it decreases the gonadotropin requirements, lower cancellation rates, increased number of oocytes, higher fertilization rate, and more women were able to have cryopreserved embryos, and you get better quality embryos from these women. However, for CoQ10 to really work, it takes about 2 to 3 months. Remember, from the follicular pool, you're going to, from pre-enteral to enteral, takes about 74 days. Just like in men, it takes about 74 days to make a mature sperm. So I start them, as soon as possible. And ideally, you need your patients to be on CoQ10 for a good 2 to 3 months before you start an IVF cycle on them. What about androgens? So this is a huge topic. So what happens in the aging ovary? We all know this, that not just in women, but even in men, the testosterone level really starts going down as we age. But it's substantially more in women. Actually 75% of testosterone production in women is from the ovaries. You get about 25% from the adrenals. And so as women age, the testosterone levels definitely drop. So can we do something to improve this testosterone level? Because remember, from the 2-cell 2-gonadotropin theory, this androgens is so critical to have a, to be converted to estrogen. So it's critical to have a nice micro environment in the ovarian follicle, and you need these follicles to have adequate levels of androgens to be able to have adequate levels of estrogens. Okay, so this is a review paper I published back in 2013, looking at all the published data up to that point, and there's more, more reviews on this. Adjuvant therapy. What about testosterone at this point? So transdermal, in case you say, my patients don't like to take DHEA and the dose is 25 milligrams 3 times a day. Is there something that we can use? So there's data on using transdermal testosterone, which also works as well. And these are few studies looking at the duration of testosterone treatment before starting gonadotropins. So the first one used it for 21 days. Kim used it for 21 days. Fabregas used it for 5. Massine used it for 15 days. And there's no real definition on how long you really should have it. So this is the slide, at least the picture that I mentioned earlier, from secondary to enteral. So pre-enteral to enteral, that's 71 days. So that's you need to have these people on DHEA and CoQ10 for at least that long. You cannot put them on testosterone for that long. You can, but there's no studies that have really looked at this. I think it would be quite beneficial, but women are going to feel weird putting a testosterone gel on their arms for 71 days before initiating an IVF cycle. So when you do that, you get hopefully more enteral follicles that grow, and therefore more oocytes that you will get. And androgen receptors are acquired from the secondary follicles up to enteral follicles and throughout the ovarian, obviously, cycle. And FSH receptors are only acquired at the enteral follicle stage. But androgen receptors are acquired in the pre-enteral, so from secondary oocyte at that point to the enteral stage. So this is one paper from 2017 looking at the use of 1% testosterone gel and showing that live birth rate is increased, clinical pregnancy rate is increased, number of oocytes is increased, number of M2 oocytes is increased, and number of embryos are increased. And this is, another review from 2019. So it really works. So what do we recommend you do? This is, again, a slide that Dr. Jatin made. It's absolutely beautiful. So this is a trial looking at testosterone gel versus placebo, starting literally a whole from day one of the cycle before the cycle you're going to start. So this is basically a 30-day trial of placebo versus testosterone gel before starting ovarian stimulation. And this is a long agonist study with a day 3 embryo transfer and using vaginal progesterone for luteal support. And these are poor responders fulfilling Bologna criteria. And again, it's basically 2 months prior to ovarian stimulation at that point. So what did it show? This is another study, actually, where starting it from day 6, from the preceding cycle, and you stop it when you start your stimulation. Okay, so you can use it day 6 from the cycle before. It's easier to remember, starting from day 1, the cycle before. So you really need to put them on a good month or 2 before you do this. This study was just 20 days before stimulation. And this is the Cochrane review. So I added these slides looking specifically at androgens in poor responders. Okay, so if you look here, you will see that both DHEA and testosterone improve outcome. So the odds ratio is 1.81 for DHEA, but you have 878 patients and the quality of evidence is moderate. So DHEA absolutely works, at least as of the Cochrane review from 2015. Using testosterone, the odds ratio are 2.6, but a much wider confidence interval because there are less patients that were part of these studies at the time. So, and the quality of the grade is moderate. So we have evidence, at least from the Cochrane reviews, that giving your patients DHEA or testosterone gel really helps, okay? What about miscarriage rates? There's moderate grading that it actually decreases miscarriage rates. Why is that? Because the oocyte quality is improved. So we've all been taught that when you do a cycle, the egg quality you get is the egg quality you have, and that you cannot modify this. I definitely do not agree with this, because the DHEA and CoQ10 and other things show us that you can actually modify positively the microenvironment where the oocyte, where the follicle is, and therefore with the cross dialogue that goes on between the follicle and the cumulus cells around it. The oocyte is not in a vacuum, okay? So it cross-talks and is affected by everything that happens in its ovarian follicle. So the healthier the follicle is, the more likely this oocyte would be euploid, okay? So I firmly believe that you can alter the follicular microenvironment to improve oocyte quality. And if anything, this data tell us that this is what's going on. So the miscarriage rate, both with DHEA and with testosterone, is reduced in DHEA by nearly 50% because the environment is better. What about clinical pregnancy rate? Same thing. I mean, if we have live birth rate, then obviously you would expect clinical pregnancy rate to be better. What about multiple pregnancy rate? There's very low information because there's very low number of patients for which. And we really try not to produce multiple pregnancies. So this is not something that, I'm really that interested in. But at least from the Cochrane review, this tells you that going on these supplements do improve outcome. So what about growth hormone? So that was my thesis when I was a fellow at the NIH. I found the growth hormone receptor in the ovary. Up to that point, people thought it worked through the IGF-1 system. It actually works through the growth hormone receptor directly and by improving the IGF system. So when we looked at it, I sent this, and 2 weeks later, it was published in JCNM as a rapid communication at the time. So the growth hormone receptor is where you would expect it to be, basically in granulosa cells, not in theca cells. And it's obviously when women ovulate, you would expect the corpus luteum to be full of growth hormone receptors, and sure enough. But you can see it in here. That's a pre-ovulatory follicle. You see a very thick granulosa cell layer, and the theca layer is completely negative in here. We found actually growth hormone receptor even in the surrounding the blood vessels at that point. And this is a corpora albicans in here, which is negative. And these are just two that are corpora lutea at this point. So what about the latest data? So this is a couple of slides from Lee's paper from Medicine in 2017, looking at multiple data from growth hormone. And you can find that there's no effect on fertilization, but obviously there is a positive effect on number of oocytes collected, metaphase 2 oocytes, and the estradiol level on the day of HCG, and the dose of gonadotropin is reduced when you use growth hormone versus placebo. And what about outcomes? So this is clinical pregnancy rate, this is live birth rate, this is canceled cycle, and this is the implantation rate. So again, at least, but when this meta-analysis was done in 2017, growth hormone seems to have helped. And looking at addition to with gonadotropin start, that's when I use it. I started with day 1 of stimulation. If you started in the luteal phase, there's not as much as a positive effect, but the problem is it becomes incredibly expensive. So in the US, using growth hormone adds about $1,000 extra to the cost of an IVF cycle. I don't know if growth hormone is available in India and how cheap it is, and that's something we can talk about during the Q&A session. So this is a paper, again, a Cochrane review from 2010, but as I told you, I showed you the Cochrane in 2015, but even in 2010, with a very low number of patients, 148 versus 131, it showed a positive effect back then. And the update, obviously, in 2015 showed this. But Rob Norman told me about this study and how hard it was for him to conduct this study. And for a period of about 4 or 5 years, he could only recruit 130 patients because nobody wanted to be randomized to the placebo arm versus the growth hormone arm. So it took him all this time, and it took him, basically 3 more years to publish the paper. But in real poor responders, he could not show a real difference. But as I said, the number of patients is really low, and he had a very, very hard time recruiting patients. So I think growth hormone does help. What about dual trigger? So if you're using an antagonist protocol, normally we would trigger, in poor responders, we trigger with HCG, but does triggering with HCG and GnRH agonist make a difference? And again, this is a slide from Dr. Shah looking at this study published in 2014, where if you use a double trigger, you got more eggs. I find it hard to believe that you get so much more, but this is what they showed in that study. They got more 2PNs, they got more top quality embryos, and the clinical ongoing pregnancy rate was 37.5% versus 0. And a follow-up study from another group, from the same group actually in Israel, showed that the same thing. So number of oocytes is a bit more. I tend to believe this study more than the previous one. Number of M2 is slightly higher. And again, ongoing pregnancy rate was 50%, but that's 12 patients in each arm. So is it worth pursuing? The short answer, yes. Is there harm to adding GnRH agonist? There is if you're planning to do a fresh transfer. So if you're planning to do a freeze all on these patients, you can definitely try a dual trigger and see if that improves things in your own practice. So this is another paper undergoing a IVF cycles with, so basically doing a dual trigger, and it showed also a slightly higher number of oocytes and top quality embryos when you do a dual trigger versus just a single HCG injection. Again, another study with significantly larger number of patients, HCG 6,500 only. Again, this is a study from China versus 6,500 plus 0.2 of triptorelin. Fertilization rate was higher, pregnancy rate was higher, live birth rate was higher, miscarriage rate was lower, and the cancellation rate was lower. So again, it's definitely something worth exploring for your patients. What about embryo banking and PGTA? Okay, so this is a study published in 2019. And this is something that we try to commonly do in the US. If you only are going to make one embryo, then you would like to, especially if this couple does not have children from before, it makes sense to do 2 or 3 IVF cycles, accumulate embryos, and then do a frozen transfer at that point. And you would expect a substantially higher number of obviously live birth rate versus those that did not bank. What about DuoStim? So again, Dr. Shah did a great job just reviewing the DuoStim literature. So the first paper came out from Italy, and the concept is there are, even within a menstrual cycle, 2 to 3 follicular waves. And that's where the concept of doing luteal phase stimulation really came from. So 68% of patients had 2 waves, 32% had 3 waves during the cycle. And the early follicular phase obviously is the ovulatory one. The other ones just, don't do anything, but there are waves that happen. So meaning if you do a cycle, you do an egg retrieval, you can stimulate another cycle the day after. And this is for fertility preservation, and this is for embryo banking, is absolutely perfect. So this is the second paper from the Italian group that was published earlier this year, called and this is what that paper was about. So 51 patients started the first stim. 6 did not respond and they were excluded, so 45 went to egg retrieval. 2, no sperm was available, so you ended up with 43 patients that had eggs. 42 patients did follicular phase, ICSI, and then 42 patients performed luteal phase cycle. 18 had euploid embryos, and 23 in the second stimulation had euploid blasts. And the primary outcome measure in the study was euploid blast rate and the number of retrieved oocytes and cumulative ovarian follicles and how many showed. And this is the protocol. So they started with 300 IUs and 150 IUs RAC-FSH plus LH. You trigger with a GnRH agonist. You absolutely need to use an agonist. If you use HCG, you cannot stimulate use a second wave. You retrieve 4 days later, you restart with the same protocol. Here you can trigger at that point with GnRH agonist or HCG if you want, because you're not going to do a third one at that point, and you do an egg retrieval. So what did they find? So that's the first cycle, so follicular stimulation, and this is the luteal stimulation. These are duostim. So this is the regular IVF cycles, and this is duostim. So cycles with more than one egg was achieved in nearly 100% of the duostim cycles, versus 96.7 for those who had just a regular IVF cycle. More than one fertilized oocyte, 98% versus 90%. Cycle with more than one blast, 88% versus 67%, and cycle with more than one euploid blast, practically nearly doubled, so 34% to 58%. So this is something that definitely could be used in your armamentarium to get more eggs and therefore more embryos. And obviously, all of these are statistically significant difference. So this is from that first paper, that 2018 paper, and they wrote in the summary that duostim is the most promising approach to increase the number of oocytes collected in a single ovarian cycle. Remember, you're still in that same month, so the patient may not get a period when you restart, and even if she gets a period while you're doing a follicular, your second stimulation, the luteal phase, you do not need to worry and just keep going at that point. So I'm getting close to the end, but I want to all of you pay attention to what we are dealing with, which is the hard facts of ovarian aging. So this is a study that was published by Sherman Silver, but it's from the Tokyo group. And in Japan, they do a lot of natural cycles. Okay, this is actually their preferred method of doing IVF. And that study looked at nearly 14,000 oocyte retrievals with natural IVF cycle. Okay, and what they're trying to find out is what is the intrinsic fertility. So what's the chance of a live birth as women age from basically less than 35 to above 42. And this table is absolutely incredible. I mean, I would recommend all of you read that paper, because for me, it was really a seminal paper. So in women less than 35, nearly 2,900 cycles of IVF, nearly 3,000 eggs, total heartbeat 845, number of oocytes per heartbeat. But basically, this is what I want you to look at. Live birth rate per oocyte. It's 26% in women less than 35. That's why I've told you before that if you have a poor responder who's young, I am always optimistic that there's a chance, okay? Even if she makes one, there's a 26% chance of a live birth. Now, this is where things start changing. So as women age, so at 35, it's 24%, not bad. 36, 21%, still pretty acceptable. 37, 19%, 38, 16%, 39, 11%. Once you hit 40 or more, this is where really things start changing. 9%, 6%, but even at 42, there's a 4% chance. And if you look at our SAR database result in the US, the chance of a pregnancy in women at 42, 43 is about 5%. Okay, at 44, you're at 1%, and by 45, it's practically zero. So when you break it down, women 43 to 54, and yes, they went up to 54 in Japan in some of these patients, the chance at a live birth is 1%, regardless of your ethnic makeup, whether this is in India or in Japan or in the US. Actually, in India, it may be even less than that, because as we all know, Indian women age, unfortunately, faster compared to Caucasians. And so do Chinese women. So for whatever reason, we don't know if it's genetic or it's environmental toxins or whatever, but this is reality. So if you're less than 42, you still have a decent chance at having a child. Once you go above 43, it becomes nearly mission impossible. Okay, there's only so much I can do, or any one of us can do. And if you plot this in a graph, you see the sharp drop. I mean, we've all been told after 37, there's really this free fall. But look at this fall. It's actually nearly linear in here. And then by the time you're at 45, it's practically that 1% chance. So when all fails, what do we do? Oocyte donation works, but unfortunately, many of our patients cannot afford to do oocyte donation and therefore cannot do anything. I know in India, the cost is substantially less, but that's still a major cost for many of these couples. So in conclusion, what about PGTA? Okay, so the value of PGTA in older poor responder is still quite vague. Okay, there's in the US, there's been this huge debate that's been going on for about 2 to 3 years, with some docs being very PGTA aggressive, and nearly 100% of their patient population, regardless of age, they really push them to do PGTA. I think this is way overkill. I'm not going to talk about if this is ethically acceptable or not. But when you have a patient that is 38, 39, and she only makes one embryo, it may be worth not to even do PGTA and just do that transfer. Because, you know, up to a couple of years ago, most IVF labs used to not report mosaicism. And there are clinics in the US that if they don't want to deal with mosaicism, so they tell the IVF labs that basically if you get a mosaic, please label it as aneuploid. And this is really sad, because mosaic embryos have nearly a 40+% chance at producing perfectly normal children, especially if they're what's called the low mosaics. So I used to be enamored with PGTA 4 or 5 years ago. I am not as enamored with PGTA at this point. But I discuss this with the patient. I give them the pros and cons, and I let them make that decision. But if they make a couple, many of my patients decided against PGTA, and then they would have a transfer. The drawback when you do this is you're probably doing transfers that should not be done, especially if you get embryos that are aneuploid. If you believe that the PGTA is 100% correlating with the inner cell mass, and it's not. I think it's at best about 94 to 95%. I've had normal babies from transferring aneuploid embryos. So I take this with a huge, huge grain of salt, and you really should also. Not only because of this, because I worry about throwing perfectly normal embryos. Remember, you're removing 3 to 5 cells from a very actively metabolic cell layer. And, you're assuming that correlation, and it's not. That's why everybody is trying to look at non-invasive ways of doing PGTA at this point, because they know even the IVF labs that do PGTA understand that there's a dilemma right there, and that we're probably throwing perfectly normal embryos. Other drawbacks, not as important as throwing a normal embryo, but the cost to the patient. Higher workload for the IVF labs. All the embryologists are fantastic. They tell you, sure, we will do it. That's not an issue. We still don't know whether doing a biopsy really harms an embryo or not. And there's definitely a debate that it may decrease the implantation potential of the embryo. So take all this with a huge grain of salt, please. So lastly, these are the Estuary Guidelines for 2019 that were published, right before the beginning of the year. So again, you have to make your own decisions, but at least in Europe, according to Estuary, agonists and antagonists are equally recommended for predicted low responders. I beg to differ, and we can go over the Q&A about this. So Clomid alone or in combination or gonadotropin stimulation alone are recommended, whereas addition of letrozole is not recommended. Okay, so no letrozole in poor responders. Higher dose is recommended over conventional dose in poor ovarian reserve groups 1 and 2. Okay, again, Europe very, very cautious in using this, the gonadotropins. Dose of 350 over 150 is not recommended in using 3 or 4. Again, I do not agree, but this is Europe. Modified natural cycle, mild stimulation is not recommended. So there are people around the world that do a lot of natural cycles. There's many papers telling you that the pregnancy rate is substantially lower compared to a stimulated cycle in poor responders. Adjuvant growth hormone, DHEA, aspirin is not recommended for low responders. Again, Europe is extremely conservative. Addition of REC-LH to REC-FSH or HPHMG is improved cycle outcome, especially if you started one cycle, which I do not recommend you do. I will tell you, do it right from the beginning. Duostim right now are not recommended except for cancer patients, but they in the updated thing that they send, they're actually looking closer at Duostim, and I believe that Duostim is probably one of the most exciting things in poor responders. In the US, the hardest part is to convince the patient that she has to pay for another cycle immediately after the first cycle. So the cost factor, I think, is a detriment for the time being. Once we get more data, then obviously that will make perfect sense. But I'm very excited about this. Now, I'm going to end with this because this needs its own talk, okay? And that's PRP. I've done 7 patients so far. The whole literature is probably less than 100 patients, okay? I really believe that in some patients, please underline, in some patients, PRP may be of help. So this is one slide I took from Dr. Shah, looking at one of the papers. I have the whole literature, and most of the literature is actually from India or Iran or China. There's 2 randomized trials going on in the US right now. One at Richard Scott's group and one at Stanford. The one at Stanford is looking at repeated implantation failure, not poor responders, but Richard's group is looking at poor responders. They're recruiting patients right now. We probably will not know the answer for about 2 years, but I have tried it in some patients. I have seen difference in some patients, and I will tell you, I think we're going to hear much more about PRP in the near future. And with this, I'm going to end and open the Q&A. Please, all of you, stay safe. I cannot wait to be in person with you at ISAR, maybe 2021 or 2022, probably 2022, more likely. And I'm going to stop here and open the Q&A per our esteemed moderators.
Thank you very much, Fadi. Your talk was really exemplary. So comprehensive. You have covered almost every aspect of a poor ovarian reserve. And I must tell you that we have more than 500 viewers and we have a lot of questions which are pouring in. So we have another 1 hour to discuss take the questions. So we'll start with the question and answer session. So the first question is, do you recommend pre-treatment do you recommend pre-treatment for all patients prior to ERT treatment?
Okay. So in terms of adjuvants, you mean?
Pre-treatment. Okay, now the question, I'll ask this question to you. Does administration of either estrogen, progesterone or COCP in previous cycle influence the ART outcome in poor responders?
Yeah. So I would say yes in one form or another. Okay. So you can use estrogen priming. You can, I personally don't have experience with medroxyprogesterone acetate in poor responders, but there have been papers looking at this showing no difference if you use progesterone, MPA versus GnRH antagonist. And it's actually much cheaper than using an antagonist. So this is something that the Chinese published first on, and they have much more experience with it. So when cost is really an issue, and you want to use, so you can use progesterone or progestins, not really progesterone. You can use progestins from day one of stimulation, and practically nobody has an LH surge. So this is another way if you do not want to pay for GnRH antagonists to use. So yes, this is one you can use. And obviously COCP, I assume, is the birth control pill. Yes, so I use the pill on some of my patients because I don't want to come on the weekend to do a retrieval or transfer and have my patients stay in the lab until 7, 8 p.m. at night. So all my retrievals are actually timed Wednesday, Thursday, Friday. We don't do day 3 transfers. We haven't done a day 3 transfer in maybe 10 years. So all our patients are pushed to blast, and I do maybe 70% PGTA because the mean age in my practice is 38. So I don't have women in their 20s or early 30s. So I use the pill for a short period of time. There's a paper that was published probably over 10 years ago now from the NIH, looking if you put patients on the pill for more than 21 days, you're going to make them poor responders. So what the pill does, it totally crashes your LH level also. So if you end up stimulating these people that you put them on the pill for 2 months with rec FSH, they're not going to respond well. So, but if you do that, you really have to use HMG to try to stimulate them. So I've never put anybody on the pill for 21 days, but for poor responders, I put them on the pill for about 3, 4, 5 days. Another way is what I showed earlier, which is a GnRH agonist pre-treatment for 3 days before. So if you get a patient that you want to start them on stimulation on Saturday or Sunday, and they come in on Wednesday with their period, you can give them GnRH agonist for 3 days before, and then they will start the stimulation. And therefore, that allows you to do your retrievals midweek rather than having to do them on the weekend. So yes, in one way or another, all my patients are pre-treated prior to ART.
Do you prefer to give estrogen or COCP?
Depends. So if there is asynchrony, I use either estrogen pre-treatment or GnRH agonist. The pill is not going to work well when there's asynchrony. So you bring somebody on, day 2 or day 3, and you're planning on starting them for stimulation, and you have a couple of follicles already growing, you should not start that patient.
Okay. Okay, the same question. This is a continuation of the same question what you answered right just now. It is day 2 scan. If there is an asynchronous follicles, do you go ahead with the stimulation?
Yeah, absolutely not. So what I do with these patients is actually follow their ovulation. So I let them ovulate. A week later, I start them on GnRH agonist. They get a period, and then I start them. So I switch them from an antagonist-based protocol to an agonist-based protocol at that point. Because if you continue with that stimulation, you're going to get a very low number of eggs, and your patient is not going to, likely is not going to get pregnant, and she's not going to be happy. And remember, when you have an asynchronous growth, remember when you look at progesterone per follicle at this point, and especially if you're planning on a fresh transfer, if you continue with this, please freeze the embryos and then do an FET. Do not do a fresh transfer. The larger asynchronous follicles are going to secrete, more progesterone than the smaller follicles, and that's going to impact your lining. And, we all have been taught that 1.5 of progesterone nanogram per milliliter is really that magical number. It's not that magical number, okay? So there's a huge difference between poor responders. That's the Veneticis paper looking at over, I think, 80,000 IVF cycles. the poor responder, the progesterone that will affect your endometrial receptivity is probably 1.2 versus a high responder, which you can easily go to 1.8 or even 2. So normal responders is the 1.5, but you have to look at your own lab. If you use a different assay, then clearly this is not going to correlate. But I will tell my patients, so I talk about all my patients about potential freeze-all, okay? So I tell them, if progesterone rises or if the embryo is growing slower, they're not going to have a fresh transfer.
Progesterone is called diurnal variation. So do you have any particular time you want to do, or what is your suggestion?
So for the progesterone, yes. So I measure progesterone anytime I'm actually measuring follicular growth. So I look not just at the value, I look actually also at the trend. And there are papers, Dr. Maduri, when she did her progesterone review, looked at that also. If your progesterone increase becomes substantial, so if you get somebody on day, for example, 6, and their progesterone is 0.8, and on day 8, now they're at 1.2, by day 5, they're at 1.5 or more, I worry about these patients. So look at the progesterone values in your own lab. But in a poor responder, if I see a 1.5, 1.6, I would rather freeze rather than do a fresh transfer. And then you can do an FET.
Okay, thank you. In a patient with decreased ovarian reserve, which do you think is a better predictor of response, AMH or AFC?
I mean, in my hands, I've been doing this for so long. For me, the AFC is really the way to go. And that's the vast majority of people in the US. AMH, when AMH came, I started using it, I think, in about 2009, as soon as, it became commercially available. For me, when I sit down with patients, especially lay people, and you talk to them about enteral follicle count, they do not understand this, okay? They do not get it. You tell them, okay, you're supposed to have 10 in both ovaries or more, and you only have 4. They look at you and they just don't understand that concept. When AMH came, you get a value and you get a range, and people understand data. They understand levels. So when you tell them your AMH level is 0.7 and normally it should be above 1.2, 1.5, they get it. So for me, the AMH the value is about patient counseling. Also, I use it quite commonly to counsel my PCOS patients. As you all know, the more severe your PCOS is, the higher your AMH level. So you use that to actually make them more compliant with your diet or your metformin and your, inositols and supplements that you use to try to decrease their ovarian, their basically insulin, to increase their insulin sensitivity. So AMH is key. In Europe, they look at AMH, but we all have had, they look at AMH more than AFC, but we all have had these patients with that do not correlate, their FC and AMH do not correlate. If those do not correlate, in my hands, I always go with the AFC.
Okay. Is there a difference in when there is a difference between the in response between HMG, one second, and combined? Is there a difference in response between HMG and combined REC-FSH and REC-LH in poor responders?
Right. That's an excellent question. No one has done that study. Okay. If you go, you pull the whole literature. You have FSH and REC-LH, or you have FSH and nothing. Okay. There's not even been a single study, and I don't think anyone is going to do that study. Comparing, for example, in the US, we only have Menopur. We don't have REC-LH. So this study is not going to be done in the US for sure. Okay. But in India, it can be done. So you can use HMG or better use Menopur because of the HCG in it. You can do a small randomized trial in your own practice. Try Menopur, for example, versus REC-FSH and REC-LH, and see who does better. So there's no data right now.
What is your guess?
I guess HMG is going to be better.
Okay.
Especially when you use HCG because of the longer half-life and because of the potency.
Okay. Okay, thank you. Yeah, I think is REC LH better than HMG in poor responders?
It depends what HMG you're talking about. I know in India, there's many different types of HMG. So in India, if you're using a specific HMG, you may get a better response with REC LH. But I always tell people, please look at your own data. So if you really want that answer, do a small randomized trial in your own practice and see which one works best. Not just in terms of number of oocytes. You need to look at implantation rate, okay? So, because there's data, you know, that I presented at Estuary, at ISAR, I was gonna present at Estuary, on the Megaset HR trial, which really tells you that, you know, Menopur is better than REC FSH in hyper responders. But there's no study in poor responders. I don't think any pharma company wants to really do that trial. Because again, as we started with, there's so many, how are you going to define poor responders? You're going to go by Poseidon criteria, or which one you're going to go by? So I would urge you to look at your own practice. Try, you know, we all, you know, what's our field called? ART, okay? It's art, because with art, you try and you see what works best for you. It's not, even in cooking, you know, you cannot always follow a cookbook. You try it and it just doesn't work as well. So you have to try different spices, different things, and see what works best in your hands. Don't believe all the data will telling you. You need to convince yourself that this is what really works.
Thank you very much. I really like your analogy of ART with cooking. I really believe you. And yeah. It's really true. Role of follicular phase HCG.
Yeah, so I discussed this briefly in the talk. I think I personally am a total believer in the value of HCG during ovarian stimulation. Again, you know, this could be also a whole separate talk about what HCG does to granulosa cells, to stimulate these, what it does to decrease progesterone levels. So all the published data on comparing, you know, I will tell you Menopur because I don't have any experience with any other HMG in the US. So you have Menopur versus REC FSH. When you use recombinant FSH, you get more follicles that grow. So the number of eggs that grow is definitely more, but the quality of the eggs you get is far superior when you're using Menopur compared to recombinant FSH. But again, try it. Don't just believe me. Try it.
Okay. Dose of highly purified HMG in poor responders. This is
okay.
From Nanda.
So that's an excellent question. So I start with 450 on all my poor responders. I don't start with less, and I never go to 600. So for me, 450 is the max I would use on these patients. Now, you can use 450 of HMG, or you can use 225 of REC FSH and 225 of HMG. So whatever makes you feel better. But don't go more than 450. I personally would not use REC FSH alone. I would definitely use HMG at least for half the amount from day one.
Okay. How do you decide which protocol is suitable in a particular patient?
Yeah, excellent. I mean, this is what this whole talk was about. Okay, so what I do, I look at everything. So I look at the patient's age. I look at the patient's BMI. I look at FSH. I look at AMH. If she's failed a prior cycle somewhere else or with me, I look at the prior cycle. You know, so I look at everything at that point. So that's what I use to use to decide on a protocol for this patient. I'm the one who does the ultrasounds on these women. You know, I don't use a sonographer. I want to see what the AFC is for this patient in my own hands, not in somebody else's. Even though in experienced hands, the inter-observer and intra-observer variability is really quite small. But, you know, if you don't trust anybody else to do your ultrasounds. So for example, in my patients, I have patients come from all over the world and other states. So I will not decide on a protocol until I brought them in on day 2 or day 3 to do my own scan. So for me, this is really critical. And then depending on what I see, then we can decide on which protocol. So if you have asynchrony in this patient already by day 2, day 3, then I switch their protocol to an agonist-based protocol. If they seem to be fine and they have, 6 to 8 enteral follicles, I may put them on the pill for, 4 or 5 days, stop it, and then start their stimulation.
So basically, do you put them in different Poseidon groups and then say, okay, now she belongs to this group? And
in the US, we don't use Poseidon groups. We use our own definitions, and most of us in the US have sort of the same definition. So we look specifically at AFC, and regardless of age, so you get a 29-year-old, for example, coming in with an AFC of 6, you're not going to start on 150. Are you worried about hyperstimulation in this patient? Absolutely not. So from the beginning, I start with 450 with this patient. So for me, enteral follicle count, and if AMH correlates, and it usually does, then there's no reason to go skimpy on the amount of gonadotropins. You worry about hyperstimulation in hyper responders or normal responders. You're rarely going to see hyperstimulation in a poor responder. Actually, if it's a real poor responder, you should never see hyperstimulation in that patient.
I think what's the best protocol for management of poor responder? I think you did answer this.
Right.
I think you have answered this question. Is there any specific protocol you want to use for hypo responders?
Right. So that's hypo responders, meaning basically Poseidon 1 and 2. Basically, you did not give them enough protocol. So if you started them with 150, and look at the enteral follicle count, look at the AMH. Okay. So if the enteral follicle count is 30, so now we're talking about those severe PCOS patients. If you start these patients on 150, they may not respond. And I'm pretty sure Madhuri completely agrees with this. Sometimes these very severe PCOS patients, especially if you haven't changed their diet, put them on metformin or other insulin sensitizers, and they're not going to respond well. So you give them 150 and you bring them 6 days later, you do an ultrasound, and there's absolutely nothing that's growing. So when you need to start increasing, go up by 75 at a time. So if you're starting at 150 and then all of a sudden decide you're going to go to 300, that patient is going to explode at that point, okay? And they're going to become the hyper responder that you've suspected they're going to be. But the dose, so for example, in my PCOS patients, I never start anybody with PCOS unless they've been on at least a month of metformin and they have changed their diet. And so the highest AMH I've ever seen was 50.4. Okay, so you get somebody with an AMH of 30 and you want to start them on 75 or 150, they're not going to respond. So take the time. Talking about the diet, I did my app mostly for my Indian patients. I have 20% in my Indian patients, and their diet is 80-90% carbohydrates. And I have two types. My Indian patients, they're either PCOS or poor responders. There's no in between.
Okay.
So please put them on it. Please start using those things on your PCOS patients before you take Agonist. The egg quality may not be as good.
Okay. So can LH be considered in an young normogonadotrophic woman with normal AFC and normal AMH? Do you LH?
So that's an excellent question. So if you have a normogonadotrophic woman, your LH is going to be low. If you have an LH above 10, that's not a normogonadotrophic woman. So the LH would be 4, 5, 6, 7. So I measure the LH only once on day 3. I do not use LH whatsoever in my monitoring during an IVF cycle at all.
Okay. How do we identify women who need LH supplementation? I think you did show us a slide.
So any poor responder needs LH add back in whatever form you want to use. Even PCOS women, the severe PCOS women, don't do that well with just track FSH. So they may even, so there's a difference between bioactive and immunoreactive LH. And again, Dr. Maduri can talk about this a whole talk probably. But you know, their LH is so high in these PCOS women. So you really need to break that vicious cycle. That's why you change their diet and you put them on insulin sensitizers and all these things.
Thank you very much, Fadi. And I think we are not yet reached that. Okay. And now I request Dr. Madhuri to take on the further questions.
Okay. Yeah.
Madhuri.
When do you test for FSH polymorphism in your practice?
I personally have never tested for this. I haven't had a patient that did not respond as I expected they're going to respond. It could be, now these are the real, the patients with real FSH polymorphism are actually not that common. And if you use the right stimulation protocol, most people are going to do perfectly fine.
So there's a question from Asha Vijay, who from Bangalore. What she's saying is, if the follicular output ratio is very low in the previous stimulation of a lady with normal ovarian reserve test and negative polymorphism, so what do we do next?
You have to look back at what your stimulation regimen was. So if you tried them, so again, make sure you have no asynchrony. Make sure that this patient does not have, I mean, if you have somebody with an FSH of 30 and an AMH that's undetectable and an AFC of 1, this patient is going to do horrible no matter what you do. So this is a patient that actually needs to go to egg donation rather than, trying to keep doing IVF cycles. So what I do in my practice, I either use HMG only or a combination of FREC FSH and HMG on everyone, okay? And the question, should we use agonist versus antagonist? It really all depends on the situation. So or estrogen priming. So estrogen priming, GnRH agonist or antagonist protocol, it all depends what specific patient you're dealing with, okay? There may not be much difference between. Sorry, go ahead.
In patients where we have used only REC FSH or pure FSH, we could add LH. We could add probably LH in this group of patients who do not have.
Right. So as I said, we don't have REC LH in the US, and we only have one HMG. So this is basically what we use.
Next, long agonist versus antagonist protocol for poor ovarian responders. What you've already told that you prefer a long agonist protocol. Then there was another question here which has come, which says that in mild stimulation, where you're using either letrozole or clomiphene citrate with gonadotrophins, whether you need to start the gonadotrophins on the day of your oral ovulations, or you start them after they get over.
I start them the same day. You want to maximize this. If you start, if you start Clomid, Clomid is a very weak agent, okay? So if that person has an AFC of 2, using Clomid and then adding gonadotropins on day 5 or 6, you probably are not going to get that much difference. But for me, I want to get as many eggs as I can. So if you want to use that protocol, I would actually start from day 1. But if you're planning on getting 1 or 2 eggs, or you're doing sort of modified IVF, like a mild stim cycle, then you can use Clomid from days 3 to 7, and then from 7 on, or day 5, you can bring them day 5 or 7 and add gonadotropins with those. But you have to understand that you're trying only to get these couple of eggs that may be there already.
Yeah. So Dr. Devi also asked further, is use of HMG better than pure FSH in such patients? And in a young poor responder versus an older poor responder, is there any advantage of using pure FSH in the younger age group and probably a combination in the older age group?
So, as I said multiple times, what I do in my own practice is if I know I'm going to have a poor responders, not Poseidon 1 or 2, if I know that they are real poor responders, I would not stimulate them with just REC FSH, okay? Because you don't want to do a REC FSH cycle and get, 1 or 2 eggs, and that patient, and they may not make a blast or whatever, or not be able to do a transfer. That patient may be unhappy. She may take her records. She's going to go to another center, and that other center is going to put her on HMG or a combination protocol from day one. She's going to do better, and she's going to go tell the whole world that you don't know how to handle IVF. So do it right from the beginning. That's always my advice. And I am so sensitive to the cost involved for patients. Many of your patients have, put their life savings or borrowed money to come and do one IVF cycle. So I urge you to please do it right from the beginning. They may never get another chance.
So what about the ovulation trigger in poor ovarian responders? Do you think a dual trigger or a double trigger is better?
So that's an excellent question. So if you're planning on doing a fresh transfer, I would use HCG only. If you're planning on doing a frozen, so you're going to do a freeze all and then do a frozen transfer, then I will absolutely use a dual trigger. Of course, it has to be in the setting of an antagonist-based protocol, okay, or a progestin-only protocol. The dose, I would go with 0.2. There's which is equivalent to 4 milligrams of Lupron that we have in the US. We don't have triptorelin, but if you believe GnRH may make a difference, go with the higher dose. But I wouldn't go beyond 0.2.
Yeah. So the continuation, I think you've answered. This was Dr. Shweta from Belgium who's asking. If we plan for a dual trigger in a poor responder, can we go for a transfer in the same cycle?
I personally would not, because, one of the things that the GnRH agonist, and that's why when they did the GnRH agonist trigger, nobody does a fresh transfer anymore. Because what the GnRH agonist does, it absolutely destroys these corpora lutea. And if you give them agonist only, you're going to see that they don't get their period 2 weeks after. They get their period 4 or 5 days after. So if you're planning on doing a fresh transfer, use only HCG. That's my advice.
But even if you use HCG as a luteal support later in a poor responder, then could you not go for
you can do 1500 every 3 days. You can definitely do that. But at that point, I'm not so sure, what the major advantage is going to be. So I will tell you, again, look at your own practice, do a quick study, 10 patients in each arm, see which one does better.
Okay.
If you give a GnRH agonist trigger for a fresh cycle, you absolutely have to give them 1500 at egg retrieval and 1500 every 3 days, which makes doing a pregnancy test so much harder at that point.
And what's your experience with dual stimulation, and whether the outcome is same with the embryos derived with the luteal stimulation?
So Dr. Shah presented his data at Estuary, which was very, very encouraging. I think he's done to date more than 50 dual stims, and he swears it has made a big difference. I've done only one. It's very hard to convince patients in the US to really try to do 2 cycles back to back. Everybody wants to know what happens with the first cycle, and IVF is so much more expensive in the US than it is in India. So I would say, please reach out to Dr. Shah. He can give you his experience, but it seems from his experience and the Italian experience, it seems to definitely be an exciting thing it's probably the best thing that's available at this point for these, until we get more experience and more data from PRP. I will tell you, a dual stim is something you should seriously look at.
Yeah, so I've actually done in about 7 patients, wherein I've done in 5 patients for fertility preservation, and I've done 2 for poor responders. So in fertility preservation, I think it's a very good option, I feel, and as we could get more number of. But the 2 patients which I did, the poor responder group, my experience was not all that good. That I mean, I really didn't get that many more oocytes, and
Right.
then probably the of the stress of freezing and again thawing also probably might affect the oocyte quality in a poor responder. That's what I think. I mean, what's your view about it?
Well, I mean, if the egg is good, the vitrification, especially if you have a good lab, that should not affect the quality of the embryo.
Even
But yes,
if it's a poor responder, I mean, if the quality of the oocyte is not good, because she's a patient of a decreased ovarian reserve, so we know that probably the quantity and quality also go hand in hand.
So I will tell you with my experience from that one patient. So she was 43 years old. So the first cycle, she got an egg, fertilized, completely died by the second day. Her second cycle, I got still one egg, but that egg made it to blast. Okay. Unfortunately, that blast was genetically not normal. So I think there is something there. And when we talk about 1 or 7 or whatever, we may not get, we need bigger experiences. That's why I said, reach out to Dr. Shah and he can tell you his experience, because I think he has done the most in India at this point. And I talk to him quite often, and he swears that in some of his patients, things have improved. Now, remember, there are patients who you do a second cycle in the luteal phase, you may not get an egg. So especially in the very severe poor responders where the AFC is 1 or 2, you may get this egg, but it may not be good quality, or you may not even the egg. So that's why the cancellation rate when you do a stim is still high.
But we also need to look at the budget for the patient, because it's almost going to cost them double. So
absolutely, that's the biggest issue that I'm facing is cost. Now, when you have somebody who you're doing for fertility preservation, this is somebody with a cancer diagnosis, then absolutely this is the perfect thing to do, and try to do as many as you can before she starts that chemo. So time for them is so critical that actually a duostim is God sent. So it's perfect for fertility preservation. For poor responders, we definitely need more experience, but the more experience is only going to come with us doing more cases.
Yeah. So what I feel, I mean, if a patient has just 1 or 2 eggs, I mean, if the quality of the embryos is good, so it's better to put them into the uterus rather than doing a double stimulation. What do you think about it?
I mean, it depends. Now, you know, if you're planning on doing a double stimulation, you cannot transfer back. Okay. And if you're planning on duostim, you have to trigger with GnRH agonist at that point. So
so when you're doing a double stim, there's no question of transferring. Right. But in a poor responder, would you think it would be really beneficial for the patient?
Yes, to do a fresh transfer.
Yeah.
Yes, absolutely. So if you look at the paper that came from Duke, I think in 2018, where they looked at the SART database and they looked at pregnancy rates. Okay. There is the only advantage to do a freeze all was in women who were hyper responders. For normal responders, and especially for poor responders, the pregnancy rate with a fresh transfer is definitely higher than doing a freeze and then do an FET. But this is based on SART database with all data. We all have gotten so much better with doing a freeze all and vitrification. So if your patient wants to do PGTA, obviously you cannot do a fresh transfer. But in poor responders, if you're planning on doing a fresh transfer and you keep that progesterone at bay and you have an embryo that's basically a nice expanded blastocyst by day 5, then do a fresh transfer. If you're doing a day 3 transfer, you can do this. But, you know, I don't have, like I said, we haven't done a day 3 transfer in about 10 years. And I take all my patients to blast. I believe that if a patient is going to, get pregnant, she's going to make a blast, even though some people say day 3, put them in. So whether you do a day 3 or a day 5 transfer, as long as you get 6 to 8 cells by day 3, the progesterone is below 1.5, especially in poor responders, I like to see it below 1, and most of the times it really is because there's not that many follicles, then do a fresh transfer. And I would suspect your pregnancy rate would be higher than trying to do a freeze and do an FET. But again, that depends on how good your lab is with vitrification.
Yeah, I also prefer doing a blast even if I have one embryo. So even in a poor responder. So I think
that's better. That's why you don't transfer 2 on day 3.
Yes. So I had read about this. Progesterone downregulation instead of GnRH analogs in a freeze-all. What's your experience about?
So it absolutely does not influence ART outcome. But when you use progestins for downregulation, you have to do a freeze-all. And the data seems very encouraging at this point. So it's a cheaper way of compared to using agonist or antagonist. It really works. So you bring these people, let's say you're starting them on day 2, 3, you start them on gonadotropins and you start them on progestins. So if you're using Provera, for example, you put them on 5 milligram every single day. And the papers that I've seen, the incidence of LH surges is very, very, very low. And the cost differential is huge.
Yeah, so there are another 2 questions on dual stimulation which I'll take is what has dual stimulation achieved in terms of egg quality and live birth rate? Right.
So again, the data is still not that much at this point, but I suspect by a meeting next year. So if I haven't looked at the Estuary book, but I suspect there may be some things on duostim. More and more people are experimenting with duostim because we really don't have anything else to offer these patients. So the Italian experience, and when I talk to Jatin, he tells me the same thing. There seems to be a higher euploidy rate from the second cycle more than the first cycle. So I think there is something intriguing enough for us to really explore more the use of duostim in your programs.
Yeah, actually there were 2 papers which were published which said that the quality of the eggs and the embryos were much better in the luteal phase stimulation as compared to the follicular phase stimulation. Right. Another question on dual stimulation is, will not the HCG of dual trigger counter the harmful effect of agonist on the corpora lutea? Because freeze-all in poor responders can be challenging.
Right. So if you're planning to do a fresh transfer, you absolutely have to add HCG as we mentioned before. So you can do a dual trigger, but then, I would use 0.1 of triptorelin, not 0.2. So use the lowest possible dose and then add HCG. As I said, 1500 at egg retrieval and 1500 every 3 days.
So Dr. Devika is saying that she has congratulated you on your talk, and she says that she uses a lot of REC-LH in her practice and is very happy with it.
Great.
So you have made a good suggestion on an RCT between HMG and REC-LH.
Right.
And she said she might try to do it.
Yeah, I think this is what everybody should do. So you're using something and you're happy with it. You may use something different and realize that you're actually happier with that. So I always urge people, try different things. We're cooks, right? This is what ART is. So try different spices, different things, and see which one works best for your taste, meaning your own program and your own patients.
So Dr. Rita is again asking on the protocol for dual stimulation, and is ovarian rejuvenation useful in any selective group of women?
Yeah, this is an excellent question. So absolutely what I would do, I would bank embryos, treat her, and then do a frozen transfer. Because you're having a poor responder. By the time she gets her TB treatment, that may take basically up to 6 months, that patient's only going to be worse than she is right now. But I would definitely not do a transfer.
Yeah, and normally after 3 months we can do a transfer, because when we are using the 4-drug regime, we really do not do the transfer. So probably we can freeze the embryos, and after 3 months.
Absolutely, you can do this. And one of the things you do when you do a frozen cycle after 3 months, you would know from the response of the endometrium if that patient has really cleared her TB or not. Thank God this is not a problem we face in the US, but I know this is an endemic issue in India.
So individualized protocols improve the efficacy, safety, and cost effectiveness of ART treatment. There are quite a bit of papers which came, in the last year, which talked about fixed dose being better than an individualized protocols. So I believe in individualized protocols. What do you think about the fixed dose protocols?
Right. So as I said,
why do they say that they're better?
Right. So as I said from the beginning, that basically individualization is really the way to go. I never use a fixed protocol on anyone, okay, except the poor responders where I use 450. But for poor responders, I've tried agonist, antagonist, estrogen priming. Again, that depends on the specific patient you're dealing with. Especially look for asynchrony, guys. So asynchrony is completely common in poor responders. Many of them grow a follicle before they even come with their periods. This is the definition of diminished ovarian reserve. If you look at many of those patients, their periods are not 28 days anymore. It's 25, 26, 24. So they're ovulating on day 10, not on day 14. And that's why when you see them on day 2 or 3, they may have a 10, 12 millimeter follicle at that point. So you cannot start them because otherwise you're going to get that one egg after 4 or 5 days. And that's not an ideal stimulation at all.
So do you use adjuvants like DHEA, testosterone to improve the outcome in terms of oocyte quality, quantity, and live birth rate?
Yeah, absolutely. So as I said before, when a poor responder, 40% of my patients are failures in other practices. So when they come in, and many of the other practices, practically none of the other practices really add adjuvants, which really, is infuriating for me. First of all, they may help. They definitely are not going to hurt. Okay. And these patients have lost substantial time because all these adjuvants need about 2 to 3 months to really see a difference, if you're going to see a difference. I did a study that I never published on about 200 patients back in, between 2010 and 2013, where I put the patients on DHEA, CoQ10, resveratrol, baby aspirin, and then I brought them for 3 months to recheck their AFC and their AMH, okay? Very few improve their AMH within 1 month. Most of the patients improve their AMH and AFC within 2 to 3 months. They actually peak by about 3 to 4 months. And beyond that, they start dropping. So this is not something that the longer you put them on it, or you put them on it for 6 months before you do anything, please don't wait that long, okay? That the improvement from adjuvants is temporary, okay? Underlying temporary. So it can help, but ideally you would want to do this for about at least a couple of months, ideally, before you do this. So what I do, I start them from the beginning when they come in. By the time I do an IVF cycle on them, most of them have been on it for about 2.5 months. So I use the HEA rather than transdermal testosterone, but both work as well. There has not been a direct comparison study between transdermal testosterone versus DHEA. Some people think transdermal testosterone works better, and I see the point because you're giving testosterone directly, not having DHEA get transformed into testosterone and androstenedione within the ovarian follicle. So it makes sense, but either of them are better than not giving them anything.
Yeah, so in my experience, though, I found that the number of eggs what you get is much more, but basically it is not converted into live birth rate. So with DHEA at least.
It may, you just have, it all depends, Madhuri, how long you put them on it. Okay?
3 months. 3 months.
3 months is perfect. 3 months is perfect. Yeah. Yes. I've had many patients fail elsewhere and they get pregnant the first cycle I do this on. But again, I cannot compare with, because I put all my patients on it. It seems to help.
Yeah. And anyway, when we look at all the treatment protocols, we also need to look at the budget, because in India, I think we have not, the insurance companies do not pay for any infertility treatment.
Yes.
So I request now Manjunath to take over the next questions.
So talking about budget, all these supplements are relatively affordable. Expensive. They're really cheap. So you can definitely,
Here
You can
the
use them.
DHEA is quite expensive.
Yeah, the HEA is quite expensive.
Yes.
Wow. Okay.
Hello, Dr. Fadi. It was an excellent talk, and
Thank you very much.
even after 1.5 hours, people are quite interested to discuss many of your things. Good.
I wouldn't expect anything else from my Indian audience.
Okay, here is a question like, what's your opinion on performing PGTA in poor responder as we have fewer embryos? I think you have discussed this, but once again, maybe. Hello.
Yes, yes, we can hear.
So, what's your opinion on performing PGTA in poor responders as we have fewer embryos?
So that's an excellent question. I spoke a little bit about it.
Yeah.
So I look at age, for example. So if you have a 32-year-old poor responder, I definitely recommend she does not do PGTA, even up to like 35, 36. If I have a 39-year-old, the thing in the US right now, patients are coming in asking for this. So it's very hard to try to change their mind, but I try. So I tell them, look, you may only make one blast. So if you are not interested in embryo banking and they're coming in for just that one child, they have one, they want to do another one, then I will tell them, if you're willing to take the chance that you may have a higher chance at a miscarriage, then we don't have to do PGTA and we can do a fresh transfer. The issue that's going on in the US right now, especially, and I would suspect it's the same thing for most women around the world. Nobody wants to deal with a miscarriage. A miscarriage is an absolute killer for women. Okay, it's not just a feel that they failed in having a real pregnancy. They got pregnant and have a miscarriage, which is psychologically devastating for many women. So it's hard for me now to convince an older woman not to do PGTA, even if she gets 1 or 2 blasts. But I try. So I try to tell them the pros and cons. And you always have to have that discussion with them. But a younger patient, I really try to twist their arms not to do PGTA, because there is no advantage in women less than 36 to do PGTA, unless you're doing it for gender selection, which is illegal in India.
And do you think that the rate of mosaicism is more with the older patients or anything like that?
No. There have been many publications on this. The rate of mosaicism is identical across age groups. Okay. It has to do with the technology itself, not with basically the not with the embryo itself or the age. So mosaicism across the board is stable. It used to be about, depending on the lab you send your biopsies to, but some of them have as high as a 20% mosaicism rate, which is really high. The lab we use right now has a less than 5% mosaicism rate, which it should be around no more than about 5 to 10%.
Okay.
And those patients that have mosaic embryos, I tell them, the mosaics one afterwards.
Absolutely. Okay, the next question what we have is, would you prefer a cleavage or a blastocyst transfer in poor responders?
Yeah,
is there any difference or anything?
Yeah, we don't do cleavage stage. We haven't done cleavage stage in more than 10 years. So all my patients go to blast.
Okay.
Because one of the things that, remember, so let's talk embryology a little bit. So the first 3 days up to the 8-cell stage is really derived by the maternal genome, which is the oocyte. Between day 3 and day 5, that's when the embryonic genome takes over. So you can have a perfectly good looking day 3 blast, a day 3 embryo that will never make a blast. And this is a classic paper that was published at Stanford, probably 15 years ago now, where at the time they were transferring routinely 2 embryos. And so if they picked the 2 best looking embryos on day 3, and they said, okay, if we're going to do a day 3 transfer, these are the embryos we put back, but we're not going to do a transfer. We're going to grow them until blast. In 50% of the times, neither becomes a blastocyst. So day 3 is a beauty contest. It does not mean that it's going to make a blast. So this is why we have gone to blast. I mean, I've been doing blast since 2003, and we've been blast exclusive for easily 10 years.
Okay. The next question we have is there role of intra-ovarian injection of bone marrow stem cell or PRP to improve the outcome with a poor ovarian reserve?
Yeah, that's again, as I said, needs its own talk. I'm not aware of experiences injecting bone marrow stem cells into the ovaries. They've done that in the uterus. That's the Carlos Simon's group at EV. But PRP, there's a growing body of evidence right now. All the studies are small, okay? But there's a growing body of evidence to suggest that it may help in some people. Now, of course, it's not going to help a menopausal woman. First of all, it's very, very hard to inject PRP in an ovary that is 0.5 cc, okay? So in my practice, I started offering PRP in January, and I have an age cutoff at 44. I don't do it at 44, so they have to be less than 44. And the FSH has to be less than 20. And the AMH has to be sort of detectable, so not undetectable. So, and believe me, we get at least 4 or 5 calls a day from 55-year-old women and 58-year-old women and 60-year-old women and 49-year-old women wanting to come and do PRPs. And totally menopausal women want to come do PRPs. So I don't want these patients, okay? I'm trying to find out who is the population that is most served by PRP. And I think it's probably younger women less than 40 with it's like the HEA. I mean, the HEA or testosterone, it doesn't do anything in women over 40 with high FSH and low AMH. They just don't budge.
We had 2 patients in a center in Pune where they had used bone marrow stem cells, and they've achieved live birth.
Yeah, did they publish this?
Yes, it's published.
Good. Okay. So I haven't been looking at bone marrow stem cells, but the preparation of the bone marrow stem cells is much, much more difficult and costly than the PRP preparation.
Yeah, they take more than 2 lakh rupees for the preparation itself.
Yeah, it's crazy. I mean, if you read the papers from the EV group about what they do to just prepare it, nobody can really afford it in Spain. That's why it's under a research protocol funded by the Ministry of Health in Spain.
Okay. You have any experience with in vitro activation of oocytes for poor responders?
Not oocytes.
Ovarian tissues?
No, I have not.
Okay.
I think there's only what's his name from Japan who has done and who has certain cases to us.
Okay, poor ovarian reserve is associated with early pregnancy loss or low pregnancy rate, even with younger age group. Any comments on that, Dr.
Yeah, it's absolutely true. I mean, there have been few papers that looked at this, and it's absolutely correct. So these women act as older than their actually chronological age. So hence, if I get a 34-year-old that, as I said, I try to tell them not to do PGTA, but if they insist on doing PGTA, I don't have a problem with doing this. But they still have a higher euploidy rate than a 37 or a 38-year-old. They will have a lower euploidy rate compared to their age group, for sure. So having diminished ovarian reserve not only affects quantity, it also affects quality, but not to as severe a degree as older women.
Patient. Absolutely. Yeah. I think we've is the poor ovarian reserve is related to an immune cause? Is there any role of glucocorticoids in this group?
Yeah. That's an excellent question. So many of women that come in with diminished ovarian reserve, now I'm pretty sure a lot of you are going to say, yes, we've seen this. When, what's the most common autoimmune disease? It's thyroid disease, right? many of these women who have thyroid disease actually have diminished ovarian reserve at a younger age compared to somebody who does not have thyroid disease, especially those who had Hashimoto's. So the high thyroid antibodies, so I tell people, look, it's an autoimmune thing. It kills the thyroid first. It affects the thyroid first, and it affects the ovaries second. But there have been many published papers on the use of glucocorticoid in this group, and it does not offer any benefit. None. So I definitely would not use it.
Okay.
So there's
Could you share with us about, we just wanted to ask about that infertility diet app, Dr. Fadi.
So,
could you share any link with us?
Right. So I did the app in 2013, actually. And because I used to get all these PCOS patients, and I would tell them, look, you need to change your diet. You need to go on a low carb diet. At the time, the most common diet, low carb diet, was the South Beach diet. And when I read it, I did not, some of the stuff that they recommend people eat did not make any sense to me. So for about 6 months, actually, all I did was read diet books. And so the best book on this is called Good Calories and Bad Calories. And I have learned things about diet and carbs and protein and good fats that we were never taught in medical school. How many of you got nutrition talks during medical school? I remember in my medical school, we had maybe 4 or 5 talks, and I skipped out on 3 of these 4. Okay, so they used to tell us a calorie is a calorie, and it's absolutely not true. A calorie from simple carbohydrates is so damaging and so inflammatory compared to a calorie from protein or a calorie from good fat. So I had to teach myself about different nutrition and different diet before I made this app. So this app is available in the App Store. So if you in the Apple App Store. So if you have an iPhone, you can download the app. But I did not do one at the time. I did not do one for like an Android-based thing. Android did not. It was starting at the time. So it's there. It's available. Basically, it's a low carb, high protein, low good fat diet. Okay, so try to avoid animal fat. So basically, I tell my Indian patients, no chapati, no naan, no rice, don't eat pasta, no sugar in anything, no potatoes. So I want them to eat more. So in the morning, to eat eggs, for those who can eat eggs. For those who cannot eat eggs, I will tell them have like plain Greek yogurt and put some, like blueberries or berries in them. So avoid sweet fruits. So they can only have green apples or berries or kiwi. Nothing, no mangoes, no pineapples, no grapes, no. So especially if you're in the south in India and the mangoes are in season, that's the killer. But I see the diet in India, for example, from change substantially towards more carbohydrates the more south you go. So rice becomes a main staple, obviously in Karnataka, of course. So people need, to avoid simple carbohydrates because the sugar spikes and therefore the insulin spikes, and the insulin acts on these ovaries to increase male production and have polycystic ovaries. So we need to start with the diet before we talk about insulin sensitizers. And it's not an easy discussion, but, especially for my Indian patients, because they have to change the way they eat. And the other thing, the food in India is so much better than the food that is in the US. So a chapati in India is healthier than a chapati in the US because the wheat in the US is horrible. Yeah. It's not the old wheat. It has been crossbred so much that basically 30% of the US population is celiac. My own daughters are basically gluten sensitive. And I've seen my daughters change in front of my eyes over a span of about 2 to 3 years from becoming gluten fine to becoming gluten completely allergic. We go to Europe The wheat in Europe, they can eat bread, they can eat these things without any issues. It's the wheat that is in the US that's the problem. And of course, everything is in the US is, everything you buy off the shelf. Everybody is busy, very few people cook at home anymore. So I urge people to really stick to the traditional. I mean, is there anything better than Indian food, healthy Indian food? I don't think there is. But avoid the potatoes, avoid the rice. So instead of rice, there's something called, you can have quinoa or something called farro, which is much higher in protein rather than rice. And avoiding the sweet fruits is not an easy thing to tell people, especially when mangoes are in season. That's really hard. But it's available in the App Store. People can download it. So I was going to write it as a book and then realized at the time that very few people are reading books anymore. So I made it into an app. There's a big table which talks about the glycemic index and the glycemic load of nearly everything that's out there. And you need to avoid food with high glycemic index and food with high glycemic load.
Yeah, it was a very nice app. I had downloaded it. So there are some more questions here. So in the Fisher protocol for synchronizing follicular growth, why wait for the onset of menses to start stimulation? Why not start after 8 days of progynova?
After 8 days of what?
Of estrogen.
You can. So you can try to do this, but when they come on day 2 or day 3, and they have a follicle that's already growing, you cannot stop that follicle. It's going to keep growing, even if you give them estrogen. So do the ultrasounds and see. If you have a 12 millimeter follicle on day 3, that follicle, nothing is going to stop that follicle. It's already well on its way to grow and ovulate. And so I did a study. In the US, for example, we do not have, all the oral contraceptives we have in the US are actually generic. Okay. And when Obamacare came in early, 2012 to 2013, all the oral contraceptives became generic. And I started seeing many more cyst formation and many more ovulatory follicles in people who were on the pills. So I did a sample of about 400. I followed 400 patients prospectively. And in 15% of the times, the pill did not suppress them. So meaning they come in on day 2 or 3, there's no follicle. The ovary is quiet. You put them on the pill, you bring them back, 10 days later, 12 days later, let's say to start stem, and they have a pre-ovulatory follicle with a nice lining, okay? So I would suspect the same as in India. Most of the pills are sort of generic. So you have to look at your own data. But this is what I'm seeing in the US. So I do not start anybody that has asynchronous ovaries. So if they have a follicle growing, I follow it. And then either I change them to an agonist protocol or to a estrogen priming protocol. Both of them work. You have to see which one works best for you.
Doctor.
Hello.
Do you think we can take 1 or 2 questions and then?
No, he's saying you can continue. Sheshan said you can continue. There's no problem.
Paddy is free.
Hello,
Are you free? There's some more questions.
I think Srinivas wants to ask a few questions on embryology. Is he there? Srinivas, are you there?
No, he's not there.
Yeah.
Sure.
No. See, worst is he has to open my this thing. Actually, I'm not able to connect my video. Audio is fine.
We can hear you.
Hello.
Yeah,
Yes, we can hear you.
Please go ahead.
Hello.
Srinivas, we can hear you.
Yes. Hello.
Yes, we can hear you.
Yes, it was an excellent talk actually. The many questions I had in my mind, so many questions has been answered as far as embryology is concerned. So my one question is that whenever we do extensive work with a poor responder, we get a good quality of oocyte, say good quality, because whenever we get all this oocyte from the poor responder, good quality of the oocyte or embryo is a question mark. Okay, I just want to ask a question over here actually. As an embryologist, he put his effort and obtained an excellent embryo. Once the embryos are transferred, whether it is a fresh or a frozen, if the pregnancy is not taken place, it is the female factor or only the embryology factor or a combination of both.
So that's impossible to know unless you've done PGTA on this embryo. So if you have a euploid blast, that's an AA or an AB grade, okay? Even in the best case scenario, you're transferring one embryo, you're looking at the pregnancy rate of about 60-65% at the most, okay? So we still don't understand what gets the embryo to really attach to the lining. So the concept of implantation is still a mystery. Sometimes what I do in these patients, let's say I have a poor responder and they have only one euploid embryo. I tell them, please do an ERA before you do a transfer. And that's endometrial receptivity assay. Because every woman has a different window of implantation. It's not unique to all women. It's not the same, okay? So in some situations, we've seen people having to do the transfer on day 7 rather than on day 6 of progesterone, okay? So before, if you have one embryo that's euploid, I will try to maximize the chances. But even in the best case scenario, you transfer a euploid embryo in a lining that should implant, you get 60-65% chance of pregnancy. It's not 100%. I don't think we will ever get to 100%. Why is that? Because there are factors we still do not understand. And it could be with the female, with the uterus itself, it could be with the microbiome, it could be in so many other things. And remember, a euploid blast, even with the best quality embryo, is not going to give us, it's going to maximize the chances. Right now, in 2020, we're looking at maybe 65 to 70%, 75% as the max. Now, for those of us with gray hair, okay, we remember that, I remember the days when the pregnancy rate was 10% and 15%. So I remember when in 1991, I was interviewing for fellowship with Zev Rosenwax, and he told me he just got Jack Cohen in the program, and we're going to get the pregnancy rate to 50%. And my jaw just dropped. That was 50% higher than what was the pregnancy rate in 1990. Okay, so now we're getting to 65 and 70%, which are rates I never thought I would see in my lifetime. But yet we're there. So how much more can we maximize? Most of the improvement has been improvements in the lab. Okay, the endometrial receptivity assay definitely is something new that has added to what we have. But there's still, implantation is still a black box. But we are so much better than where we were even 5 years ago. So
can we increase the success rate?
So before I tell you about that, so kudos to all the embryologists like you who are making us look better. So you make us look better or you make us look bad. Okay, thank God most embryologists these days are making us look better. So you can work with only what I give you. So if I give you bad eggs, you cannot, if I give you broken eggs, you're not going to be able to make an omelet. Okay, so you work with what I give you. So if I give you bad eggs, no matter how phenomenal you are, you can only do so much. So the ideal scenario is obviously a physician or a group of physicians who know what they're doing, who stimulate things right, and a fantastic group in the lab. We're the only thing in medicine where we have to rely on another person to make us look good. If you're a cardiologist, you're a surgeon, you're fine. You're a dermatologist, you're fine. Only REs rely also, so we work as in tandem. It's not, I am not separate from you. We are together in this, which there's no other field in medicine that has this.
Yes.
So, okay. Any advanced technology in the embryology lab is going to improve the success rate?
So what
like time lapse studio?
Right. So obviously you need to have a phenomenal lab. Okay. So the media now are mostly all, commercial. They're all about the same. They all work well. So some work better than others, but I'm talking, at least in my lab. So we are at a point where we have achieved, the best possible that we can do in the lab. The issue goes back to how good are the eggs I'm giving you, meaning how good I'm stimulating these patients. Am I doing my patients the best thing, or I am making them have bad eggs when I can improve egg quality a little bit? So you don't know what's going on with the patient. You know when you get the eggs. You just don't know what's really has happened with the patient, how hard we've worked to get to this point. And you get these eggs, and we expect you to make beautiful blastocysts by day 5. But all of us are conscious of the fact that we can only expect so much from all the hard work that you're doing in the lab. So vitrification.
So my last question is, and in your talk you mentioned that you do only blastocyst transfer. When we work up with this poor group of patients, when you get less number of egg, is it worth doing a blastocyst?
That's fine. That's fine. We still grow to blast. I mean, I've grown.
So day 3 transfer in this case, what if
even with one
blastocyst transfer?
Even with one egg, we push them to blast. If the egg quality is good, then they should. So what's the blast rate in my program? It's about 50%. Okay. Right. So look, when you get a day 3 embryo and you transfer it in this patient, you do not know if this embryo is going to continue and become a blastocyst. There's actually a study going on right now that hopefully will finally answer this debate in the literature. Some people tell you it's better to put it in the uterus and then see what happens. But remember that when you're putting a day 3 embryo and the pregnancy, the blast, pregnancy doesn't happen until you get to a blast and implant in the lining. So you're putting a day 3 embryo in the uterus that's not supposed to be in the uterus. It's supposed to be in the fallopian tube still. And you're putting it in the uterus, and the surprising thing is pregnancies were happening. Okay? But the study that I think is being done at Boston IVF right now is which way is better. Should we grow all embryos to day 5, or should we transfer on day 3? So this is what they're trying to do and answer this and once and for all. If it shows that, no, there are people who get pregnant on day 3, that they may not make a blastocyst by day 5, then we would start doing more day 3 transfers. If it shows that, no, there's definitely an advantage to grow even one embryo, one egg to a blast, then this is what we're going to do.
Now, definitely, as you said, day 3 to day 5, there is almost a 50% reduction of embryos, saying no that no, whatever the medium, what we use is a suboptimal medium. So
no
that
doubt.
Means we are just letting this embryo, only 50% of them are coming up to the blastocyst. Rest of them will not, because medium what we use is optimized.
True, but that's not the media. That's normal. Okay, yeah. That's normal embryology. That's normal embryology. As I told you before, the embryonic genome does not become active until after the 8-cell stage. So before, the oocyte looks good, but the sperm is bad. Okay, you have a nice looking day 3 embryo. It does not mean it's going to produce a pregnancy or become a blastocyst. So I have no qualms about growing them to blast. Now you have an embryonic genome at that point. So it really gives you the full potential of that embryo. Is it going to implant or not at that point?
What is your cancellation rate if you are taking them to blastocyst, even if it is a one oocyte? What is the cancellation?
Well, luckily, I don't have many that have only just one. So with two, there's a good chance. I've had, women make two eggs, 2 fertilized, 2 blastocysts. So again, the younger you are, the higher the chance you're going to make a blast. The older you are, the lower that chance. But that's normal embryology. You're not going to make a 42-year-old have 50% blastulation compared to a younger woman. But if we look, when we looked at our program, and we did that last week, for 2019, 2020, we are at 50% blastulation rate, which is phenomenal.
Yes. Finally, can you use this artificial intelligence to evaluate the embryo before you
Yes.
do the embryo transfer and predict the pregnancy rate?
So there's definitely been some presentations on using AI for this. That obviously takes a lot of resources, a lot of time. You know, if especially, you know, it's ideal if you have an embryoscope, look at all these things. We don't have the money to get an embryoscope. I don't think we really need an embryoscope. You know, I have a small boutique program, so, you know, I don't have the resources to try to look at AI, but AI definitely has a place, especially in these big programs, because they need to know who has a higher chance at getting to blast or not. But there's a lot of work on this right now.
Okay. Thank you so much, Fadi.
Thank you.
There are a few more questions. Do you have time, Fadi, to answer?
Sure, go ahead.
I am living.
Yeah.
Hello.
So,
Hello.
they're asking for the dose of tamoxifen
Okay,
and for how many days do you give? And then what is the dose of gonadotropin you use in these patients?
Okay. So if I'm using tamoxifen only, so it's 20 milligrams compared to 50 milligrams for clomid. So I use 40 milligrams days 3 to 7 or 4 to 8 or 5 to 9. Okay. If you're doing a combined, with gonadotropin, so I start on day 3 and then by day 5, you can start your gonadotropins at that point. If you want to make it even cheaper, you can start on day 7, but you may get less eggs than if you start on day 5.
There's another question. Does addition of growth hormone make a bigger difference compared to maximal stimulation with 450 units?
Yeah, that's an excellent question. There's not much data on this, as I said, but I use, Omnitrope, which is the growth hormone we have in the US, 4 IUs per day. Now, obviously, you know, if you use a higher dose, you may see a better response, but the cost becomes really an issue. So I use sort of 4 IUs for the 9-10 days of stimulation. And obviously I stop. The last dose is the morning of the, trigger. And I tell patients, look, you know, you failed cycles before. Okay. I'm going to try to give you the maximum. It may help. It certainly will not hurt. Okay. But it may help. And we may get a better quality egg that makes a euploid embryo. So since we don't have much to really offer, that's what I would recommend we do.
Yeah. So the other question is same as when you, what's the dose and when you start. So you've already mentioned that.
Yeah.
Then
Do you check LH level while starting stimulation? Would you recommend menopause even if day 2 LH is above 3 international unit?
No, I do not. I do not.
Okay. So anything else left, Madhuri?
Yeah,
I think
1 minute. Yeah. 1 minute. I'm just going through them.
I think we have done everything.
Poor responders. 1 minute. What is the percentage of oocytes that? Yeah. What is the percentage of oocytes that show dysmorphism in your center? And do you see any fragile eggs in this group of patients? Is a question by Dr. Sapna from Hyderabad.
So what's the instance of mosaicism in embryos, right?
No, dysmorphism. That is.
Dysmorphism.
Yes.
So obviously in poor responders, we see eggs that don't look that great. So we see vacuoles, we see black spots. So what's the incidence? I really have not looked at the percentage, but I will tell you these are quite common. It's the biggest, the double whammy is the older women with diminished ovarian reserve. So you know the young ones have better oocyte quality because they're still younger. So the worst thing is, you know, women in their early 40s that have, dark cytoplasm, vacuoles, and those are very, very unlikely to make blastocysts.
So what is your age and AMH cutoff to consider for oocyte donation?
So obviously age is the biggest thing. So if you get a 46-year-old with an AMH of 1 and an FSH of 8 and she has an AFC of, 6, obviously her chance of getting pregnant using her own eggs is less than 1%. So those, I tell them, they need to go straight into egg donation. But there's no, so yeah, Otherwise, you have, let's say you have a 38-year-old with an FSH. So when your FSH goes above 20, especially above 30, and your AMH becomes undetectable, and your AFC is 0 or 1, these people really need to look at oocyte donation. If they're probably, can they try PRP before moving on to egg donation? The short answer, if we get many patients who would not do egg donation at any cost, they will not do it, even if they have the money. So I am not opposed to trying PRP on them. But I had a discussion yesterday with a patient. Her FSH is 39 and her AMH is undetectable. I told her, look, it's 99.99%. It's not going to be of any benefit to you.
Yeah, so there's another question for the down regulation with progesterone. Can you use natural progesterone instead of medroxyprogesterone?
I don't think it will suppress the gonadotropins or the axis enough. So those, I expect they will have a much higher incidence of LH surges. So I would rather use progestins rather than natural progesterone.
Then somebody is asking that PGTA tested embryos also abort sometimes. So is it really mandatory to do PGTA even in older women?
Of course not. Yeah. So this is a choice. It's not something we force on people. I've had 42 years old not do PGTA and get pregnant with perfectly normal children. But you have to remember that by 42, your chance of a miscarriage is probably about 40-50%, and they're all because of genetic anomalies, or the vast majority are because of genetic anomalies. So it's definitely, I would not turn a patient down if she comes and tell me, I don't want to do PGTA. I've had these patients and I perfectly do transfers on them, and they've had perfectly normal babies. Much less commonly, though.
Yeah, I think last two questions are there, Madhuri. Yeah. Should we really wait for withdrawal bleed after luteal phase estradiol? A stimulation can be started next day of 8 days of estradiol.
Absolutely. So you can start the next day. Once they get a period, bring them in and you can start them the next day.
Okay. What is your take on gonadotropin dose affecting the oocyte quality? Considering the standard dose for poor responders 300 IU in conventional stimulation and not more than 115 mild stimulation, how do they fare with respect to oocyte or embryo quality?
So that's an excellent question. So there at ASRM last year, there were two papers, one from RMA and one from Cornell, with huge numbers. I think the one from Cornell is already published in Human Reproduction at this point. I already reviewed it for them. But there is no increase in aneuploidy rate with increasing gonadotropin use. So if you go to 450 compared to 300, you're not going to see more aneuploids in the 450 versus 300. So you can rest assured that in poor responders, you are not doing harm by going to 450. But please do not go beyond 450, because at that point, you're making the patient poorer and the pharma companies richer, which is fine, but we don't want the patients to be poorer. There's no scientific reason whatsoever to go above 450.
Thank you very much, Fadi. I think we have answered all the questions that was put across. And may I request Manju to conclude the session?
Dr. Fadi Sharara, it was excellent, and thank you so much personally and on behalf of Karnataka chapter of ISAR. And it's really fantastic. Anybody can speak for continuously for more than, I think we are reaching almost 2 hours. Yeah. It was very good of you. Thank you so much, and look forward to you for any future talks in our conferences.
My pleasure. My record in India was actually 3 hours. So we started at 7, and at 11 o'clock, I think Amol had to step in and say, we need to finish because we go to bed. And the amazing thing, no one had dinner. So everybody ate afterwards, and I've never seen this anywhere in the world. Okay, in the US they would have been long gone. It's just totally different. So I wish all of you the best. I will please stay safe. This is a very weird time for us to be living in, but hopefully we will all meet preferably, at ISAR or when I come visit India next.
Sure. Thank you so much,
Thank you.
Dr.
Thank you very much, Paddy, for accepting our invitation. And we'll see you soon again. Bye.
Thank you.
Thanks.
Stay safe.
Thank you, Dr. Shobana Patel and Dr. Madhuri Patil, madam. And thank you for all the audience. I think 500 plus viewers were there. Thank you so much for joining us. And I would special thanks for the ring people, Mr. Amol and Mr. Vishwanath, for arranging this webinar. And special thanks for again Science Intriga, Mr. Shubbu and Mr. Seshan. Thank you so much. Thank you,
everyone.
Thank you, everyone.
Bye-bye.
Bye. Bye.